it's not indicated to jump right away to trauma processing, talking all about the trauma. That will be way too much, too fast. And it can overwhelm the client, and they may even start getting more desperate.
G'day, and welcome to Wellbeing. I'm Jack Hodgins. Today we are talking with Dr Bethany Brand, a clinical psychologist and Towson University professor. Dr Brand is an expert in trauma and specialises in the assessment and treatment of trauma-related conditions such as PTSD. In this episode, we are discussing complex PTSD recovery. Complex PTSD is considered to be a more severe form of PTSD and is commonly developed following trauma in childhood. Hello Bethany, and welcome to Wellbeing.
Thank you very much.
What is complex PTSD?
It's described differently according to which authors you're reading, but in general, I would say that it's post-traumatic stress disorder, PTSD, that occurs typically when there's been ongoing chronic trauma, often developing from childhood trauma, when the child is still developing their sense of themselves, their view of others, and their stress response system, so that there's a lot more than just the PTSD symptoms. For example, they might have dissociative symptoms. They may have more interpersonal relationship troubles, those sorts of things. Another one that's very common to see is that they have a difficult time regulating their emotions. That's fancy for saying they feel too much or they feel too little. They kind of go back and forth between the two.
What makes complex PTSD different from normal PTSD? Is it that it develops in younger people that go through traumatic events?
It tends to be associated with developing from childhood ongoing trauma. But if adult trauma is severe enough, like if somebody is held captive and tortured, for example, even in adulthood, that can be enough to cause complex PTSD. But in general, there's more symptoms than just the intrusive symptoms of PTSD. So the intrusive ones are, for example, thinking about it when you don't want to think about it. It's really disruptive. It just the trauma pops into your mind, or a picture of it does, or flashbacks. And when that happens, you're really upset emotionally and physically. Your heart may race. You may feel sick to your stomach. So that's the intrusion cluster of symptoms. And then that's so unpleasant. People do their best to not think about it. So there's an avoidance cluster of symptoms. So they try not to think about it. They try not to talk about it. They try not to go around people or situations or anything else that might trigger it. They also, in regular PTSD, they have alterations in how they think, so they may think that the world in general is dangerous. People in general can't be trusted, or they themselves are just bad people. So those are patterns of thinking that can change. They also have, typically, and they don't have to have every last one of these symptoms, but it's, the majority of these symptoms they might have from time to time. But another one for regular PTSD is that they may have changes in their emotions. So they may feel a lot of anger or shame or sad, tearful a lot. And then the last cluster for regular PTSD is that they have physiological changes, hyperarousal, so they may feel irritable, jacked up, and not able to calm down, or they get really, revved up, startled easily. They have trouble sleeping because of all that. So that's the normal PTSD, classic PTSD, sometimes called simple PTSD. Complex involves typically all of those clusters of symptoms, plus the psychological term is emotion dysregulation. So feeling too much or too little, emotions really being all over the place. And that can include numbing out. That's one type of dissociation that they might have. And then the problems with interpersonal relationships as well. Some of the authors add in that they may have changes in their sense of meaning. So for some people, that means they lose faith, or they never can develop a sense of faith in spiritual well-being or a God, or that there's any purpose to life. Those additional symptoms are added on top of regular PTSD.
So would complex PTSD affect the brain differently than, say, normal PTSD then?
That's a good question. And there's research that's emerging that's looking at these things, but we don't know definitively. I'll give you an example, though, of one pattern that really is emerging with lots of research around the world. And that is, in regular PTSD, if somebody who's got that is put in a functional MRI machine, so a brain scanner, and of course they're told about this study, and what's going to happen. They give their permission to do the study because it's asking a lot of somebody. Before they go in the scanner, they tell their story of trauma, like exactly what happened. And they tell it in first-person script. So I am driving down the road and I see the car in front of me slam on the brakes and I hear all this squealing of tires. They describe it like that. The researcher writes all that down. And then, so that's called their trauma script. Then they go into the brain scanner. With regular PTSD, when their story is read back to them, their trauma script, the parts of the brain that have to do with fear-based hyperarousal, a lot of people may know about, like the reptilian brain, the limbic system, the amygdala, are firing. They're working really hard. They're very activated. And there's all this flooding of emotion and fear. Often, probably a lot of the listeners have heard of the fight or flight response. So if somebody would run or attack if they can't run away, that's the part of those are the parts of the brain that normally light up, get very activated. But what we're seeing in the more dissociative types of PTSD, so that could be complex PTSD, or it could be somebody who has complex PTSD, but also along with that, what's called a dissociative disorder. They may detach emotionally and physically from their body so that they feel numb when they shouldn't, or they feel at a distance from their body like it's not even their real body, or they may see themselves at a distance like they're watching a movie of themselves, for example. Sometimes they literally feel numb in their body so that they may not feel pain when they're actually, the body's injured or they have an illness. So what we see at those kind of situations is that when somebody dissociates in the scanner when they hear their trauma script, is that some parts of the brain are shutting down, like the parts I was mentioning earlier, more of the primitive crocodile brain, if you will, the limbic system, the amygdala, are less active, and the front of the brain, the prefrontal cortex parts of it, a part of the brain called the insula, there's other parts too, that those are parts of the brain that might, for example, tune into how the body is feeling, like the insula. It looks like those parts of the brain are less active. And so, yes, that was a long-winded answer to your question, but yes, it may present differently in the brain, in brain scans, and we're just starting to figure out some of these things. I'm not a neurobiologist. I don't do the scanning research myself, but I'm aware of at least, a fair amount of it. We know that the brain connectivity, the brain networks that fire together, that there's alterations in those patterns as well. So yes, trauma does impact the brain, and it looks like it may be over time that we learn that different types of trauma, different types of PTSD typically show up differently in the brain. It's pretty amazing research.
Would you say then that recovery with people with complex PTSD looks different than those with normal PTSD?
Yes, I do. So one of the things I didn't mention about complex PTSD is that people are often struggling more with self-harm, like it may be cutting, it may be burning themselves, it may be hitting themselves, or it could be suicidal thoughts, and sometimes they act it out with suicide attempts. All of that tends to be more common in people who've got complex PTSD. And so when they first get into treatment, and they also are more inclined to have addictions, for example. And so the treatment provider, if they've been trained in complex trauma and how to manage it, they hopefully will do a really good assessment right in the beginning to find out what are the person's presenting symptoms. What is really going wrong right now for this person? Is it primarily like safety? Is this somebody who's very much struggling just to stay safe and alive? And if that's true, then they should focus on helping the person get stable with safety. I know this may not sound like rocket science. Normal PTSD treatment, a lot of clinicians jump right to having the person talk all about their trauma. And that can be fine if somebody doesn't have, for example, a whole lot of safety concerns or, active addiction. If they do have those problems, or dissociation, let me throw that in there because that's important too. If they dissociate a lot, they're numbing out a lot, they're disconnecting from their body, and they may even have gaps in time. They can't remember, minutes or hours a day. If they have any of those things, and there's some other things you might look for as well as a clinician, but if they have those serious symptoms, it's not indicated to jump right away to trauma processing, talking all about the trauma. That will be way too fast. and it can overwhelm the client, and they may even start getting more desperate, which is the last thing we want. They may even feel more inclined to self-harm. They may feel even more depressed, or like their drug or alcohol use might increase. So it's very important that people get assessed well by somebody who knows trauma, including complex trauma, and that the treatment targets the symptoms they have and at a pace they can tolerate.
I would imagine then that those with complex PTSD find it very hard to ask for that initial help.
It's often the case because, to go back to what we were talking about with how they view themselves and others, they often feel very bad about themselves. I'll give you an example. In the United States, we still have the death penalty. And so I do some forensic work sometimes with people who have been alleged to commit murder, and that's usually why they get sentenced to the death penalty. And so I meet with them either, before they've been sentenced or after they've been sentenced. And I recently met with somebody who already had been sentenced to death, and her attorneys are appealing it. Anyway, the important point is that she completely felt like the reason she was so terribly abused in childhood, and then she had a violent relationship with men in adulthood, she thought that that was her fault. She thought that she just wasn't good enough, that somehow there was something about her that made people abuse her, take advantage of her, and that if she just was a better person, smarter, more attractive, more lovable, it wouldn't have all happened. So you can imagine somebody like that may have a much more difficult time reaching out for help because they feel so bad about themselves. And, not very many people are really feeling proud of themselves when they call up for therapy.
Yep.
It's a courageous step for anybody. But then you add to that the sense that I'm a bad person. If you add to that, if they have the thought other people are going to hurt me, shame me, think I'm bad if they really get to know me, it makes it doubly or triply, whatever. It makes it harder to go in for treatment.
When do people then usually seek help with their complex PTSD? Is it when they've hit rock bottom, for example?
For some, yes. And it can be pretty desperate, rock bottom. Others, it depends on many things. But younger people, for example, are sometimes seeking help now. It's becoming, among that cohort especially, less shameful to go and get therapy. And so I'm a college professor. I hear younger people talking about that much more often than people in my generation. Although, even there, it's now pictured in TV shows and, on series. So there's a little bit less stigma, but some people really do. They only go in when some pretty serious losses, like a relationship loss, or I'm thinking of one of my clients where she knew the way she was drinking she was going to die. It was very, very clear because of her symptoms. And so she first got herself sober and eventually started figuring out that, as she got sober, the memories of trauma were coming back more, and she had to get into treatment for that.
So how do you as a therapist kind of approach these things? Like how do you approach these like really raw issues that people come in with?
You have good questions. So from the beginning, I teach a course called the Initial Diagnostic Interview. And so I teach students and I follow what I teach. From the beginning, I try and really understand the person and listen very well and try and help them see, even if in that first session or two, like what are their strengths, not just all their symptoms and problems. So for example, it does take courage to come in for help. And so I might point that out, or other things. Maybe they've got a good couple of friends. And, that's an important resource, especially if somebody's had a lot of trauma in their lives. They may not feel like they deserve good friends, but they might have a couple or one. Or maybe they're very loving to pets. I mean, it can be all sorts of things. But I look for strength. And I try and help them understand how they got there. From, early on. It takes a while, obviously, for me to understand them and know about their life story. But I try and help them understand, let me just give an example without revealing too much about a case. The person I was just talking about, who is already on death row, she had a what to her was a strange symptom. She would pluck all the hairs off her body with tweezers. I've heard of that before, because I specialize in trauma. I've heard some of these symptoms that may not make sense to the average person. And she'd been sexually abused by men. And I asked her, do you have any idea why you do that? And she laughed, kind of embarrassed, and said no, and I get teased about it, but I'll spend hours on it per day. And I said, do you think it's possible that it's because you can't tolerate having your body look at all like the men's bodies who abused you? And she just, her jaw dropped. So that's an example, like helping them understand their symptoms are symptoms, not something weird about her or, whoever it is, not something that means that they're weak. It makes sense. And so sometimes I'll explain, like you were asking earlier, about the brain. Sometimes I'll explain, like you dissociate. That's called dissociation when you numb out and can't feel your body. When you, see yourself at a distance while you and your husband are intimate. There's a name for that. It's called depersonalization. It's an out-of-body experience, and it's what happens to our brains under extreme threat. And you probably learned to do that, to distance yourself from what was happening when you were a kid. Anyway, so I'm explaining symptoms and helping them understand themselves, and then I start teaching them ways to manage symptoms, and it makes them feel much more in control and much less crazy, because they feel crazy sometimes, even though they're not. These are just the impacts of trauma.
You're listening to Wellbeing, a nationally distributed radio show and podcast. My guest today is Dr. Bethany Brand, an expert in complex PTSD recovery. How much support specifically for complex PTSD is out there?
My guess is it depends where people live, and so let me explain that. In the United States, for example, many mental health professionals are not taught about complex PTSD when they get training for social work, psychology, psychiatry. They don't even learn much about what dissociation is, and that's one of the cardinal features, one of the cardinal symptoms of it. They don't learn much about it at all, how to assess it, how to treat it. And so I think it depends if you live in an area and can do some research and find out, are there clinicians who know complex trauma? Then from the mental health field, if you're able to find those people and if it feels like a good fit, you're going to get more support. If you happen to be lucky enough to have support groups in your area or friends who know something about trauma, the person may get more support. But there are obviously many people whose significant others, loved ones don't understand, even regular PTSD, much less complex PTSD. So if they are willing to learn about it, read about it, that can be pretty helpful.
Overall, how affordable is it for people to get help with their complex PTSD?
Again, that's going to vary so widely by country. So in the U.S., there's a system where it's not socialized medicine, and it will depend entirely on whether they have mental health benefits, if they have a job, or if they're on some kind of public subsidy like Medicare or Medicaid. So I don't know around the world how to really answer that. I know, in places of socialized medicine, there's some help. What I hear occasionally from clients when I do international talks is that, I'm thinking right now of the UK, United Kingdom. My understanding there is that they have very few specialists for treating dissociative disorders, very few. And they typically do short-term treatment. And so complex trauma, complex PTSD takes much longer. It's not treated in 12 to 16 sessions. Like, some of the studies show you can treat simple PTSD, let's say from a car accident. The person had a good enough childhood. They have not had lots of interpersonal trauma, and they've just had a really bad car accident. Yeah, that's feasible to treat that in, 6 sessions, 10 sessions, 12 sessions. But if you're talking about ongoing interpersonal violence, usually by a loved one, like whether it's a child or in a partnership, for example, that's not going to get better in 12 to 6. It can make progress, but it's not going to be healed. Like you were kind of saying at the beginning of the session, it might be somewhat more manageable. So I think in many countries, there's still a really significant need for more support for people with complex trauma and complex PTSD.
Is it possible to recover from complex PTSD, or is it something that we manage more than recover from?
Again, really good but really hard question. It's going to vary. In my experience, it's going to vary. So let me just take little nibbles at answering that.
That's all right.
I could go on about 2 hours on that one. One of the things we know is that childhood trauma that's prolonged, if especially it involved an attachment figure, a caregiver who was supposed to protect the kid, and instead they betrayed the kid, abused the kid, didn't protect the kid. Maybe there was, a step-parent or, a partner in the household for a while who was abusive, and the other parent didn't step in and stop it. So there's betrayal there. And especially if that happens in early childhood, it can mess up what's considered attachment. So I'll just say a little bit briefly about that. In the first 3 years of life, more or less, if parents, caregivers, whoever's taking care of the child consistently, are repeatedly, for the most part, very reliable and respond to the child's cries and distress. And it happens over and over again. Anybody who's parented knows it just happens constantly sometimes. If mostly the parent is good enough and is soothing and calming to the child develops an attachment style that's called secure. They come to believe, even though they certainly can't put it in words at that age, they come to believe that others are reliable and that they are lovable enough to deserve that kind of really good treatment. And they have much better outcomes in life because they expect good things and they know how to respond to it. And they, at least it's one of the things that can make people treat themselves better. If that doesn't happen, and let's say the parents are struggling with their own mental illness or substance abuse or in and out of prison, or, parents are working multiple jobs and, caregiving is sort of up in the air any day who's going to take care of the kid and, how well they do that. Those kids are more likely to have what's called insecure attachment, so they may cling in relationships, or they may have a dismissive style where they're like, I don't need anybody overall. They don't like to get really close in their, closest relationships. If somebody comes in with that, we know from research that the security of attachment can change in either a really good partnership that lasts for some years, like a really reliable partner, like a spouse, or a really good therapeutic relationship. So that attachment, the whole thing we really weren't talking about with complex PTSD, but it's part of it,
okay.
Especially if it happens in those developmental years. So we know that can change. And the symptoms, people can learn a lot of ways to manage symptoms. And some people respond, well to antidepressants and some of the other meds, that might help them too. So I have absolutely seen people get so much better. Some people I've worked with were on disability, some kind of a disability where the government was paying for their subsistence, but basically sustenance. And then I've seen other folks where maybe they're in still violent relationships, or for whatever reasons, maybe they don't respond as well to medication, maybe they don't have good current social support, and they have a much harder time healing. All of that said, most people show improvements. If they're willing to work at it, most people, and they have a good therapist, they really are able to make substantial improvements in their life. And I'm going to just jump to the next question that you might ask. Can we totally heal the brain? Can we ever make it like they didn't have that traumatic childhood or that really violent, marriage? No. There's no going back that way and erasing it, at least not that we know of now. And, it's part of who the person is, but there can also be, not to minimize anybody's trauma, but they also may have developed some strengths. I'll give you an example. So one of my clients, he's obviously struggled a lot, and he would do anything if he could erase a childhood, but his tendency to be anxious and see how things could go wrong, now that it's not crippling, he's responded very well to regular talk therapy and an antidepressant that helps with anxiety. He is now very good in his career. He's doing a brilliant job because he's talented and he works hard, but also he says his anxiety helps him tune into how things could go poorly so he can think ahead and outmatch other people in the field. I'm not going to say anything more just because of privacy.
Yep.
But there's some value. There can be value. I've seen people with incredible compassion towards others because they have some sense of how much others might be suffering, and you can't see that on somebody's face most of the time. We don't know what other people have gone through, but they're incredibly compassionate. So there's a lot of reason to hope, a lot of reason.
Yeah, and I think that's something that we should really highlight, is that people that do go and take recovery and do get that help, they can live full and happy lives, even though they may still have the complex PTSD in there, but they can manage it and they can live great lives. Is that?
Yeah. I agree with that, and it helps, obviously if they get a partner who loves them. I'm thinking of several people I've worked with, a number actually come to mind, who had just lovely partners, and, one person's partner struggled with something else, not necessarily trauma, but they loved each other, just dearly loved each other and helped each other through the times that they were a little more symptomatic, and so, one was in recovery, but didn't have the trauma history, and they supported each other, and, nothing was perfect, no marriage or partnership is, but they had good lives.
What environment do you need to curate for the clients to make sure that the best environment is created?
I take that seriously. So I want my office to be really restful. And so I like plants a lot and flowers. So I try to have, attractive, peaceful environment and, not too frilly. I want men and women to feel comfortable in there.
Yep.
And I want it to be quiet and peaceful. So I choose the colors, thoughtfully. Strangely enough, there's actually one school of therapy where they don't want people to do long-term work, and I actually had a therapist say he chose not to have a very comfortable set of chairs in his office, and I don't work that way. Therapy's hard enough. Let's make people comfortable.
How well, at this point in time, do we understand complex PTSD in the recovery sense?
I do research as well as do therapy, and so I can think of so many things we still need to learn about the treatment in terms of research. So if I answer from a researcher's point of view, I'll say, there's so much more we need to learn. But if I will answer it from a clinician's point of view, there's really good training out there about how to help people, real expert trainings, phenomenal books for therapists, phenomenal courses for therapists to go to. And so I think, maybe we haven't shown everything in research, and I'm all about research too. Complex PTSD, like I said, doesn't get better really fast. And so if you want to do a study, in the United States, I can talk about that more knowledgeably. If you want to do a study where there's randomized assignment, that's the gold standard in research. You randomize half the group to one treatment and half the group to another. So it could be, the one get one kind of trauma treatment, the other group get another kind. That's the gold standard for proving any treatment, whether it's medication, psychotherapy, or cancer treatment. That's the gold standard. You have to do randomized controlled trial. Well, that's much more easy to do if you have a 12-week kind of treatment and a disorder that's going to get better in 12 weeks. But what if complex trauma takes, months and actually often enough years, depending on what the person's goals are? So I'll come back to that in a minute. So the standard treatment trials, they could cost $3-4 million to do a short-term treatment trial. But if you're asking now for years of treatment, that's one of the reasons we don't have as much research on complex trauma, because it's so much more expensive. And it's hard to run studies that have to run for a couple of years because people's lives change and they can't stick with the same therapist and they move on. And also, I do those kind of studies, but I'm one of the first that has found a way to do that with dissociative disorder patients because of what I'm just describing. In the United States, our biggest funder for research for mental health, the government funding agency, has never funded a study for the treatment of dissociative disorders because it's a long-term treatment, it's very expensive, all kinds of reasons. Anyway, so I think anybody listening who has a loved one who has complex PTSD or they themselves have it, I think that we know a lot about how to help that. I know in Australia they have the Blue Knot organization. It's Blue Knot. They've got a great website as one example, and a lot of resources on there. So if anybody listening wants to look that up, that might be useful for some of your more local resources.
How can a family member or a friend of someone that does have complex PTSD help that person?
The most important thing is to show and to say that you love them and you're there for them. You want to help them and to ask how you can help. And, of course, that's going to change all the time. So when they're feeling really down, maybe they just want to watch a lighthearted movie or, just cuddle together, depending on the relationship, of course. Or, do something that's invite them to do things. When somebody's depressed, they don't want to do anything typically. And so just see, would they be willing to get together, to have a meal with you or to go for a walk in the park? It may not be very high-level exercise, but, could they just spend some time with you? Or, would they allow you to bring over a meal and you just eat together if they're not really up to cooking for themselves at that point? If it's somebody who has nightmares or a flashback, you always have to ask the individual, is this okay? And work it out in relationships, because some people wouldn't want this. But, for example, if they're looking really terrified, in their mind, it may be that they're back in the trauma and it's happening again in their mind. Or they may, let's just finish that one. So that's a flashback. And just talking quietly, calling their name, saying, I'm here. Let me say it's me as an example. You're here with me, Bethany. We're at home. It's May 5th, 2022. You're okay. You're safe. It's not happening now. It's not happening now, to try and really get them out of the flashback or nightmare. People, I'm sure, have heard about the horrible nightmares people have with PTSD. They may wake up screaming and crying. You don't want to necessarily touch them. You have to figure out with that person, is touch okay in the middle of a flashback or a nightmare that actually could frighten them more? So just a calming, reassuring presence first, and say, would it be okay if I held your hand? Or what would help? How can I help you now? So you're showing the care. You're helping them see you're there. You're asking them, how can I help you now? That can go a long way towards helping them not feel so alone.
You're listening to Wellbeing, a nationally distributed radio show and podcast. My guest today is Dr. Bethany Brand, an expert in complex PTSD recovery. Where do you see the complex PTSD recovery sector going in the future?
I would love to see all clinicians learning about it and in their training. I would love to see that. And there's more and more certifications coming up for therapists to get a level of certification to show I've had really good trauma training. So we're having more of that. And I'm sure that's happening in Australia as well as in the U.S. and other places. In Europe, they have a different diagnostic manual than we use in Australia and the U.S. Here, it's the Diagnostic and Statistical Manual. People may have heard of the DSM. That's the Diagnostic and Statistical Manual of Mental Disease. That's how we diagnose disorders. Like, that's literally all the disorders that are recognized in the countries that use that. It's like the Bible, if you will, of diagnosis. In Europe, they have the ICD-11, and in Europe, in that new version, ICD-11, they have included complex PTSD. The U.S. and others who use the DSM we don't have that yet. It's not been included. It's been a debate among scholars and researchers, and ultimately, a group was pushing hard for it in this DSM-5 that we're now using. They did not win, but I see there being a lot more research trying to validate that, there's different types of PTSD. In that recent DSM that came out, the DSM-5, they did add a dissociative subtype to PTSD, which captures more of those complex symptoms we were talking about earlier. So that's a step in the direction of recognizing complex PTSD, which, at least in the countries, I think most countries require this. For a clinician to bill an insurance company, or whoever the organization is that's paying for treatment, you have to generally have a diagnosis. And so with complex PTSD recognized as a diagnosis, it just makes it easier for them to get reimbursement. Now, most clinicians would just diagnose PTSD and, go ahead and bill under that, but it doesn't quite capture the breadth of symptoms and that person might need longer treatment than, say, the person who had a bad motor vehicle accident. So I think we're going to be having more and more recognition of trauma, its complexity, and the complex impact of complex PTSD. There's this huge upswelling in research showing that, for example, what are called adverse childhood experiences. Listeners want to search for this online. Adverse childhood experiences, they're called the ACE studies, ACE. And now they've been replicated around the world, and it's amazing how this is changing things, especially in the U.S., which I know about, but I know it's happening in other countries too. We have research that shows that for every type of ACE, adverse childhood experience, somebody has gone through, that child, through adulthood, has a greater chance of all kinds of psychological disorders, behavioral problems, and even health problems. So, for example, if somebody's had no ACEs, they have literally longer chance of living. They have, when you look at huge samples, they live longer on average. But if the child experienced sexual abuse, plus physical abuse, plus emotional abuse, plus had a parent with mental illness and a parent who went to prison, that's 5 ACEs I just counted up. They have a much higher risk of having all kinds of problems, addictions, PTSD, depression, suicidality, all kinds of problems. And now that research has been shown so consistently around the world, it's literally it's filtering down to pediatricians. They're learning about it, like to ask about ACEs, to help try and support families. So it's amazing. It's gratifying, and just wonderful to see that some of this basic research is starting to filter down into school systems, into the medical field, and certainly, gradually it's getting out there to all mental health professionals where it should have been already, in my opinion.
So from all we've talked about, Bethany, in this interview, for those that are listening, what would be the take-home that you'd want them to remember the most?
You have been traumatized in a relationship. It does not mean that you are a bad person. Whatever symptoms you have are symptoms. And symptoms like cold symptoms, flu symptoms, there's a lot you can do to treat them and to feel better about yourself and to feel in better control of your symptoms. There really is reason to hope.
Well, thank you for being on the show today, Bethany.
My pleasure. Thank you very much for the kind invitation. It's been really interesting to talk to you. You've got really great questions.
My guest today was Dr. Bethany Brand, a clinical psychologist and Towson University professor. Tune in next week where we discuss PTSD recovery in military veterans with a clinical psychologist from charity Mates for Mates. And if you like this content, check out the Wellbeing podcast for more. Thank you for listening. I'm Jack Hodgins, and all of us at Wellbeing wish you well.